lecture for the 2021 Integrated Fertility Symposium. Our topic today is insulin resistance and polycystic ovarian syndrome, the expanding role of inositols. And our presenter is Dr. Mark Ratner, and this lecture is sponsored by Theralogix, so a big thank you to Theralogix. And my name is Lauren Brown. I'm your Clinical Director of AccuBalance Wellness Center in Vancouver, and I'm the chair of the IFS, the Integrated Fertility Symposium. I want to do a little bit of housekeeping and just let you guys know kind of what's happening and what you want to know about this lecture and Theralogix. Again, a thank you to Theralogix for putting these lectures together. If you go to the IF Symposium website, you can see the recordings from a previous lecture from Theralogix and this one as well. The website is ifs.healthyseminars.com. Go to sponsors and then find Theralogix. And when you scroll down, you'll see information about Theralogix. You'll find out that they have a special going on for those as part of the Integrated Fertility Symposium, and I'm sure they'll open it up to those that are here live today as well if they want to take advantage of their special. Handouts for this lecture are available through Theralogix, so please contact Theralogix directly. You can go through the IFS sponsor page for Theralogix to contact them, or just Google them and go to their website directly, and they're happy to share handouts for this lecture. They also did a lecture earlier during the IFS, which is excellent, by Dr. Mark Ratner on CoQ10 and female fertility. It is excellent how Mark broke it down about embryo quality, egg quality, and the embryo quality, and the role of coenzyme Q10. He talked the difference between ubiquinol and ubiquinone. Really great lecture. And up here was the Q&A. So there's a Q&A part as part of the lecture. So you can watch those recordings on the IFS website until August 31st. And they're also available on our social media page at Healthy Seminars and the Integrated Fertility Symposium. And then here's the lecture we're going to do today. So it's just under 29 minutes. So that recording's here, and we'll put the Q&A up as well as soon as that's over. And again, that's the sponsor page for Theralogix if you want to watch those recordings. I do want you to know, excuse me, for those that are part of the Integrated Fertility Symposium, if you're signed in and you go to the forms and you click on special offers, you can see offers that all the sponsors have made for you guys at the IFS. And if you scroll down to the Theralogix on August 30th, they say that they extended their offer to August 31st. So you can check out the Theralogix post under special offers in the forums. And again, if you're watching this lecture, contact Theralogix. Maybe they have a special for you. Maybe they're willing to offer it. Let them know you watch this on the Healthy Seminars website or the IFS website. I'm speaking of Healthy Seminars. Just so you know, these community lectures and sponsor lectures like today, we keep listing them under the resource page. And so if you scroll down, you can see here we are on August 23rd, 2021. This is today's lecture. And then anything that's happening, we list down this page. So you can keep scrolling down. You can just see some of the offerings that we keep adding to the website. And this is where you grab your links. So I just want to let you know that. All right. So again, our topic is insulin resistance and polycystic ovarian syndrome, the expanding role of inositols. Our presenter today is Dr. Mark Ratner. He's a medical doctor. He's trained in nutrition and used to be, or I don't know if he still practices, but in andrology. And so we already seen some private message questions that came into me earlier about men and my inositols. So Dr. Ratner will talk about that during the Q&A as well, since you have that background in andrology. Just want to let you know about our disclaimer. This is for educational purposes only. This is not intended to be medical advice, so do not perceive this as medical advice. This is for educational purposes only. If you do have a health condition, please do seek out a healthcare provider. All right, let's bring up the recording. So we're going to do the replay now. Please post your questions in the chat during this live replay, and I'll moderate those because we do have Dr. Mark Ratner here, and we do have some of the admin and runners of Theralogix here to answer questions. So Dr. Ratner will answer questions about the science, and we have people from Theralogix to answer specific things about their products and promotions. So without any further ado, Dr. Mark Ratner on our topic on insulin resistance, PCOS, and inositols.
Hi, this is Dr. Mark Ratner at Theralogix. In this video, I'll explain the concept of insulin resistance and the role that it plays in PCOS, the most common cause of infertility in women under the age of 35. I'll also explain the role that inositols can play in improving insulin function and correcting many of the issues that are caused by PCOS. So we'll start off with some quick review of the basic concepts that underlie PCOS, or Polycystic Ovarian Syndrome, and then we'll talk about the role that insulin plays in the underlying issues that PCOS patients face. We'll talk about inositols, which can function as insulin sensitizers, and explore the basic science that explains how they work. And finally, then we'll talk about some clinical trials that have been done over the past years that demonstrate the benefits from inositol use. And lastly, we'll talk about Obesity, which is the Theralogix product that we released about 6 years ago, and which has really tremendous benefits for women experiencing PCOS. So PCOS, or Polycystic Ovarian Syndrome, affects about 5 to 10% of all reproductive age women. And it is considered to be the most common cause of female infertility for women under the age of about 35. There are 3 primary diagnostic features, and generally speaking, if a woman has any 2 of those 3, the diagnosis of PCOS is made. The first is absent or infrequent ovulation. So women who are not getting their period every month, who may go many months or even a year or more without getting a period. The second would be clinical or biochemical evidence of increased testosterone, and that doesn't necessarily even require blood testing to see. You could oftentimes just check it out on physical exam. You might see that the woman's got thinning hair, which can be an effect of testosterone excess, or sometimes excess hair, facial hair, body hair, and skin issues like acne. All of those can be a sign of excess serum testosterone. Finally, the third feature is polycystic ovaries on ultrasound, which is obviously something that would be done in a gynecology office to check out whether or not those changes are seen in the ovaries on sonography. And so once a diagnosis is made and the woman has PCOS, there are a wide range of clinical effects that she might be experiencing, and that might have brought her to the attention of a healthcare provider. Obviously, infertility is a big one. If she's not getting a period on a regular basis, it's kind of hard to get pregnant if she's not ovulating. Obesity, a significant issue here. 70 to 80% of all PCOS patients have an elevated BMI. Dermatologic and hair issues, we've already mentioned. Increased risk of metabolic issues like type 2 diabetes, gestational diabetes during pregnancy, metabolic syndrome, cardiovascular disease. And so the key is that patients, women with PCOS, may be seeking assistance for metabolic issues or reproductive issues, or both. So, what are the standard approaches that physicians have used, OBGYNs and fertility doctors, over the years to deal with this condition? Well, for reproductive issues, one of the first things that they'll try is ovulation induction using oral fertility medications like Clomid or Letrozole to sort of force the ovaries to ovulate. If that doesn't work, they'll go to IUI, intrauterine insemination, and sometimes in vitro fertilization or IVF. For metabolic issues, the first approach should always be diet, exercise, and weight loss, which can improve many of those issues that we mentioned a moment ago. But oral contraceptives have been used because that will increase sex hormone binding globulin, and that will then reduce the amount of testosterone that's circulating. And Metformin, an insulin sensitizing drug, has really been a mainstay of PCOS treatment for probably 20 years or more. And the reason why Metformin, an insulin sensitizer, is used for women with PCOS is because insulin plays a key role in the pathophysiology of this condition. insulin resistance is the key. And I'm going to explain to you what we mean by insulin resistance. Let's go back up a little bit here and just kind of go through some of the basics about insulin. Insulin's a hormone, and its job is to allow our cells to take in sugar from the bloodstream and then either burn it for energy or store it in the cell as glycogen for later use. Insulin is produced by the pancreas, which is an organ that's found just behind the stomach. And when the level of sugar in our blood rises after a meal, let's say, the pancreas then releases insulin into the bloodstream. So in this illustration, we see the bloodstream here and a cell there. And we have on the surface of the cell what we call the insulin receptor. There are also what we call glucose transport proteins on the surface of the cell. And so after a meal, glucose starts to build up in the bloodstream. That will then stimulate the release of insulin from the pancreas, and the insulin binds to the insulin receptor. Once the insulin receptor is activated, it then releases into the cell what we call second messengers. And those second messengers then allow the glucose to come into the cell, where it can either be burned for energy or stored as glycogen for later use. And so the key to understanding this is that those second messengers that are released by the insulin receptor and allow glucose to enter, be burned for energy or stored for later use, those second messengers are made from inositols. And that's why inositols are really key to understanding insulin resistance. So what are inositols? Well, inositols are 6-carbon sugar alcohols. They're in the same family as sorbitol and mannitol and xylitol, which we've all heard of. Inositols are part of our diet. We get them in many fruits and certain beans and legumes. The average U.S. dietary intake is about 800 to 1,000 milligrams of inositol per day. So this is a common feature of our diet. There are actually 9 different stereoisomers of inositol, and there are 2 of those which actually serve as the second messengers for the insulin receptor. So here are the 9 stereoisomers. Don't worry too much about the structure here, but the 2 that we worry about are called myoinositol and decairoinositol. Myoinositol is by far the most common form. 99% of the inositol in human tissues is in that form, myoinositol. And myoinositol serves as the second messenger for the insulin receptor, and it also is involved in FSH signaling in the ovary. Decairoinositol is only 1% of the inositols in human tissues, but it also serves as a second messenger for the insulin receptor. The key thing to remember about myo and decairo is that we get the decairo that we have in our cells by conversion of myoinositol through an enzyme called an epimerase. And so that epimerase enzyme converts myoinositol to decairoinositol in our cells when the decairoinositol is needed. That epimerase enzyme, the activity of that enzyme is driven by insulin. And so the more insulin in the area, the faster that epimerase enzyme works, the more decairoinositol would be produced. So we've got these 2 different inositols, myoinositol and decairoinositol, and they are converted. Myo is converted into decairo by what we call an epimerase enzyme. So remember that because it's going to be important in a second. All right. It turns out that the ratio inside the cell between myoinositol and decairoinositol is different depending on which tissue of the body that we're looking at. And that ratio is critical in determining how that tissue responds or doesn't respond to insulin. Okay, so most PCOS patients have a condition that's called insulin resistance. Much more common in women with high BMIs, but even women who have lean PCOS can have insulin resistance. And let's go back and explain what we mean by insulin resistance using the same illustration that we used a moment ago. So this is what we see after a meal. Again, this is what happens normally. You've got blood, you got the sugar in the blood, the glucose is in the blood after a meal. And the insulin binds to the insulin receptor, and that releases those second messengers, Decairo inositol and myo-inositol, into the cell. And the sugar comes into the cell, and it again is either burned for energy or stored for later use as glycogen. So what can go wrong? Okay, so in this situation that we're going to show you next, we've got, again, glucose in the bloodstream after a meal, okay? But in some instances, the pancreas fails. And so you don't really get enough insulin in the bloodstream. So therefore, the insulin receptor doesn't get activated, the sugar cannot get into the cell, and you start to get a buildup of glucose, sugar, in the bloodstream. That buildup of sugar in the bloodstream, we call that hyperglycemia, right? And this is what you see in type 1 diabetes. Basically, failure of the pancreas to make enough insulin. Okay, what else can go wrong? In some instances, again, we're back to the basics here, back to the beginning. After a meal, you've got sugar in the bloodstream. In this case, the pancreas is working fine, and you've got insulin in the bloodstream, and the insulin binds to the insulin receptor, except the release of the second messengers is wrong. And the ratio of those second messengers between myo and Decairo is out of balance. And so if the release of second messengers is abnormal, once again, sugar cannot get into the cell, and it's going to build up in the bloodstream. Except in this instance, the pancreas is normal. And that excess sugar in the bloodstream stimulates the pancreas to start making more insulin. And so you get not only hyperglycemia, but you start to get excess insulin building up in the bloodstream, which we call hyperinsulinemia. Okay, so this is what we call insulin resistance, where the second messengers don't allow the insulin receptor to trigger the proper sequence of events, and you get not only hyperglycemia, but you get excess insulin in the bloodstream because the cell is resistant to the insulin. Okay, most PCOS patients have insulin resistance. We said this a moment ago, but the hyperinsulinemia, that excess insulin in the bloodstream that is caused by insulin resistance in the peripheral tissues, meaning fat, muscle, the liver, that excess insulin leads to negative effects in the ovary, which we call the DCI or Decairo inositol paradox. And let me show you what that means and how that works. So this whole process of insulin resistance, it starts in the peripheral tissues, meaning our muscles, the fat cells in our body, when the epimerase enzyme is abnormal. And so if the epimerase enzyme, which under normal circumstances converts myo-inositol to Decairo-inositol, if that enzyme is abnormal in the peripheral tissues, you don't get enough conversion of myo to Decairo. And so you have too much myo and not enough Decairo in the peripheral tissues. That leads to reduced glucose uptake, and it causes hyperglycemia. And the hyperglycemia, which we just showed you a second ago, leads to excess insulin production in an insulin-resistant patient. And so you get hyperinsulinemia. But the hyperinsulinemia then increases epimerase activity in the ovary because the ovarian epimerase enzyme is normal in this situation. And the excess insulin caused by the insulin resistance leads the ovarian epimerase to increase its activity. And so in the ovary, you get too much conversion of myo to Decairo. And so the end result here is that in the ovary, the Decairo inositol level goes way up and the myo inositol level goes way down because that epimerase enzyme is cranking because of the excess insulin in the bloodstream. So because of the excess Decairo in the ovary, you get excess testosterone production. You also, because of the reduced myo in the ovary, you get reduced FSH signaling, and those two things together lead to both poor egg quality and failure to ovulate. So the whole thing starts off with insulin resistance in the peripheral tissues. So how can using inositols as a supplement correct this problem? Well, there are a number of studies that have now been done, almost all of them in Europe up till now, and they started about 10 years ago. So this situation, this study right here, which was published in 2009, treated 50 women that had PCOS with 4 grams of myo-inositol daily for 6 months. What they found was that compared to their baseline levels, serum testosterone decreased by 30% and insulin resistance decreased by 50%. 30% of the patients had disappearance of hirsutism, their excess body hair, and 53% of the patients had resolution of acne. So this was a nice early study which showed the metabolic improvements that inositol supplementation could yield. This study, which was published roughly at the same time, randomized 42 women with PCOS to either inositol or placebo daily. The inositol group had a significant reduction in their serum testosterone compared to placebo, a significant reduction in serum triglycerides, and a significant reduction in the amount of insulin in their bloodstream over the course of every 24-hour period. So another example where you had significant improvements metabolically with the use of inositol supplementation. Finally, insulin sensitivity in this study improved by 80% using inositol compared to basically no change with placebo. So how about comparing inositols to what has been the standard treatment, metformin, for many years? This study, which was published in 2010, took 120 women with PCOS who were not ovulating and randomized them to either receive metformin or myo-inositol every day for 6 months. And what they found was that the metformin group had a resumption of ovulation in about 57% of the women and a live birth rate of about 17%, whereas the women who took myo-inositol had a significantly improved ovulation rate of 70% compared to metformin and a live birth rate of 26%, again, statistically significantly better than the metformin group. There has now been a number of studies which have even shown even greater benefits of myo-inositol and Decairo-inositol supplementation together compared to metformin. If you talk to a lot of reproductive endocrinologists, the docs that do IVF, they're going to tell you that IVF can basically take care of the problems that PCOS-based infertility creates. And that really all you need is the IVF cycle to get pregnant. But in fact, there are now studies which show that if you add inositol supplementation during the IVF treatment process, it actually can improve results. And there have been about 6 randomized controlled trials, over 900 patients combined in those trials, looking at pregnancy rates in women with PCOS who are going through IVF with ovulation induction. And so compared to the control group, these women receiving inositols during IVF had about a 14 to 15% reduction in the dosing of fertility drugs that they needed. They had an increase, statistically significant increase in the number of high-grade embryos that they produced. Their miscarriage rate was reduced by 66%, and the clinical pregnancy rate improved by 21%. So using inositols during IVF treatment actually improves the outcome of IVF for women with PCOS. So then the question arises, well, is it better to use myo-inositol alone or a combination of myo-inositol and Decairo-inositol? And the key to understanding the answer to this question is that in PCOS women, the peripheral tissues are deficient in Decairo-inositol, while the ovary is deficient in myo-inositol. So the peripheral tissues need a little bit of Decairo-inositol supplementation, while the ovary needs myo-inositol supplementation. And so the physiologic ratio in the plasma of normal individuals, non-PCOS individuals, is about 40 to 1, myo to Decairo. And so the most recent studies, and actually the two large US-based studies that are now underway, are using an intervention which is a 40 to 1 ratio of myo-inositol to Decairo-inositol. This is a study that was actually published about 8 years ago, in which they actually looked at metabolic outcomes, and they compared myo-inositol alone to a combination of myo-inositol and Decairo-inositol in that 40 to 1 ratio. And what they found was that for fasting insulin, the area under the curve, 24-hour area under the curve for insulin, and actually even fasting glucose, the combination of myo-inositol and Decairo-inositol was significantly better than myo-inositol alone. The current NIH-funded study that's underway at Penn State Medical Center is using the Theralogix product, Obesity, which is a 40 to 1 myo to Decairo product. And it is assessing metabolic endpoints, including serum testosterone, sex hormone binding globulin, and then measures of insulin resistance as well. So that brings us to the last section here, which is Obesity, the Theralogix product. The treatment that we have to use for these women should consist of, and this is really based on what the majority of studies have used over the past 10 years, supplementation with about 4 grams per day of a 40 to 1 ratio of myo to Decairo-inositol. That will restore physiologic ratios, normal ratios in both peripheral tissues, reducing insulin resistance, and in the ovary to improve egg quality and ovarian function. Myo and Decairo given in combination will improve both metabolic and reproductive endpoints in most PCOS patients. However, in terms of setting patient expectations, most studies have used at least a 3-month, 90-day intervention, at which point we can expect to see improvement in ovulatory function. But in terms of androgenic, testosterone-based issues, that can take up to 6 months of inositol supplementation to start seeing significant improvement in sort of dermatologic and hair issues. Another principle is that we want to avoid high-dose Decairo-inositol because that will have an adverse impact on the ovary. Remember, the problem in women with PCOS is that there is too much Decairo-inositol in the ovary, not enough Decairo in the tissues. So what they need is a little bit of extra Decairo for their tissues, but you don't want to give too much because that would then impact ovarian function in an adverse way. Finally, keep in mind, inositol supplementation is inexpensive, It's non-prescription, it's safe, and extremely well tolerated. So the Theralogix product Ovasitol is a 40-to-1 Myo to Decairo blend. It is an insulin sensitizer, and it restores ovulation and reduces serum testosterone and improves insulin sensitivity. It is NSF content certified. That's an independent third-party nonprofit certification program that the product goes through. NSF is based up in Ann Arbor, Michigan, and it is a freestanding nonprofit which certifies all Theralogix products for content accuracy and purity. This is a pure inositol product. It has no additives or excipients. It is the product that was chosen for use not only in the ongoing Penn State Medical Center study, but in a new inositol study that's now being done at the University of Oklahoma as well. The dose is 2 grams twice per day of Ovasitol powder, and the cost is as low as about $65 for a 3-month supply. So what about safety and side effects? Well, doses of up to 18 grams per day have been used in clinical trials without any safety issues whatsoever. Although if you get doses above 4 grams per day, patients will occasionally complain of mild GI upset, perhaps primarily loose stools or excess gas. This is really key. The use of inositols during pregnancy is not only safe, but in multiple studies, it has significantly reduced the risk of gestational diabetes mellitus. There have now been 5 randomized trials over the past 7 or 8 years, including nearly 1,000 patients. And what they've basically shown is that inositol supplementation during pregnancy results in a 50% reduction in gestational diabetes and a 65% reduction in preterm delivery. Absolutely no adverse effects reported. So, to summarize, the key takeaways: Myo and Decairo inositol play a key role in insulin receptor signaling. Low levels of Myo inositol in the ovary will impact ovarian function and egg quality, but elevated levels of Decairo in the ovary will cause excess testosterone production and are not good for women with PCOS. Supplementing with a 40-to-1 ratio, much more Myo than Decairo, is effective, and it is as effective as metformin in reducing insulin resistance and excess testosterone production, and it will improve metabolic endpoints in most PCOS patients, and it will also restore ovulation and improve fertility outcomes in actually both PCOS patients and now also in non-PCOS patients. That's been shown as well. So thank you for watching. If you need patient samples, educational materials, office program information, here's the contact information. And once again, thank you for your attention.
All right, I want to thank Dr. Mark Ratner for that lecture. And also I want to thank Theralogix for sponsoring this for the Integrated Fertility Symposium. We got lots of questions in the chat and that have been sent to us privately. So we got a bunch of questions we're going to go through. I want to just highlight a reminder here that on the IF Symposium website, ifs.healthyseminars.com, we do have the past lecture on CoQ10 and female fertility and the Q&A up. It is excellent, like excellent. I really highly recommend if you're treating reproductive health and you're supplementing with CoQ10 to watch it. And if you're treating fertility, reproductive health, and you're not supplementing with coenzyme Q10, then you really want to watch that lecture. And then we're going to put the Q&A up here. But if you want to watch this lecture again, it is up on our page here on the sponsor page for Theralogix. And the handouts for both the CoQ10 lecture and this lecture, because I know there was a lot of research that was shared and you want to kind of see the copies of those research and those slides, then do contact Theralogix directly. They said they're happy to share with you the handouts from this lecture and to share more information about the product information. It's really great to be able to have science, like research behind the nutraceuticals at this day and time. So it's nice that and the group from Theralogix as well are getting people to do the science and do the research so we can understand better the mechanism and clinically how to use this. All right, Mark, let's get your microphone ready. I just want to ask Ian, do you have anything you want to share about Theralogix right now, or wait until after the Q&A? I will let you know that if you're asking about IFS specials, because I know they have specials, just contact Theralogix, ask them about the handouts, and just say, what's the IFS special? And I'm sure they'll pass that on to you guys if it's still available. So Ian, any comments or questions before we rapid fire Mark with these questions?
Yeah, well, it's certainly more important to have Mark's commentary, but yes, I posted my email in the chat, and then of course you can follow the landing page. The wholesale 15% off discount is extended until the 31st of August. Also, too, we have a special coming with another product, Canabrex. In the month of September, we'll be offering all your patients 20% off on that product. So if you'd like to learn more, just reach out and we can start a dialogue. So hand it over to Mark, Lauren. Thank you.
All right, Mark, here we go. So first question. It seems clear that the 40-to-1 Inositol is superior to my Inositol alone for metabolic benefits in PCOS patients. So the 40-to-1 ratio, my Inositol to Decairo. Is there evidence that the reproductive outcomes are also superior using a 40-to-1 product versus just using my Inositol alone? Do we know that conception or live birth rates are improved when we use a 40-to-1 product over just my Inositol alone?
So the short answer to that question is there is some evidence, but for the most part, what we're doing is extrapolating from the metabolic data. And the reason that we have to do that is because clinical trials, studies that would look at reproductive endpoints, the most important endpoints being live birth, those take huge study populations. The big NIH-funded trial that was done comparing Clomid to letrozole in women with PCOS, it was published about 6 years ago in the New England Journal. They enrolled 800 couples because that was how big a study you needed to do to power those endpoints of pregnancy and live birth. Studies that look at metabolic endpoints can be much smaller. Now, there was a study published in 2019 by the group in Rome. I think the principal investigator was Nordio, where they looked at, I think, 6 or 7 different ratios of Decairo and Mayo. They went, I think, as high as a 1-to-1 ratio of Mayo to Decairo, all the way up to 80-to-1 Mayo, 80 parts Mayo, 1 part Decairo. And they looked at restoring ovulation. But that study only had, I think, 8 women in each arm, in each different ratio. And the reason is because they're just too expensive to do these trials. There's no big pharmaceutical company behind it. This inositols are over-the-counter dietary supplements. And so it's very hard to fund these trials. Now, that study that was published in 2019 did show that 40-to-1 restored ovulation more reliably than any other ratio. But it was, admittedly, it was not a statistically significant result because you just can't power a study with 8 women in each arm and expect to get that kind of data. So the answer is we know without question metabolically 40-to-1 works best. And since those metabolic improvements are what yield the reproductive enhancements, the improved ovulation, the improved egg quality, we pretty much have to extrapolate in some instances.
Thank you for that and the explanation behind that. So now, not somebody with PCOS or insulin resistance, just kind of like CoQ10 using it for egg quality, therefore embryo quality. The question is, some centers include inositol in the recommended supplements for IVF. Does it offer any benefit to egg quality in someone who does not have PCOS or known insulin resistance? So basically, prophylactically, or using it as an egg quality enhancer. What about using inositol as an egg quality supplement, but no indication of insulin resistance or ovulatory disorders? Can it have a negative impact? Can it have a positive impact?
I think there are several studies now that show in non-PCOS women undergoing IVF that inositols can improve outcomes. So the answer to that question is a qualified yes. Now, why would that be? Because we know that myo-inositol also serves as a second messenger for FSH, for follicle stimulating hormone. The inositols, and it's actually inositol phosphoglycans as a family, are second messengers for multiple different hormones, not only insulin, but FSH and thyroid stimulating hormone as well, TSH. So yes, there are reasons to think that myo-inositol can enhance egg quality in non-PCOS women going through fertility treatment. Would you use a combination product in those women? It's never been compared. Arguably, the presence of the Decairo, the 40-to-1, and the small amount of Decairo there is really targeting the peripheral tissues with the Decairo to try and reduce the insulin resistance in the peripheral tissues and reduce the hyperinsulinemia. So in theory, a woman who was not insulin resistant might not benefit from that small amount of Decairo. Would it hurt? Don't know.
Thank you. Follow-up question that is, how do we respond to IVF clinics, reproductive endocrinologists that are currently telling their patients to stop taking the Decairo in a combination with myo and Decairo, and they're quoting that there are studies showing that it negatively impact embryo quality in IVF setting? So how do we counter this with evidence to support using the 40-to-1 in an IVF setting or during that 3-month lead up to an IVF cycle?
I have not heard that. I mean, look, we have, I would say more than half of the IVF practices in the country, I should say in the United States, that is, are using, and many in Canada as well, but are using Theralogix products. So we interact with these programs all the time. I've not really had a lot of pushback. I've not heard pushback from reproductive endocrinologists about some adverse impact on embryo quality from either myo or Decairo. The clinical trials that have now been done using inositols through pregnancy, not only for PCOS, women with PCOS, but women who had high BMI or had an elevated fasting blood sugar during their first trimester. All of these different risk factors for gestational diabetes have been studied by giving them inositols, and it has significantly reduced, about 50% reduction in gestational diabetes, no evidence of preterm birth or preterm delivery, and no evidence of any kind of impact on embryo quality. So I'm not familiar with anybody expressing significant concerns about that.
Okay. And that question was, I think there might have been a study once upon a time where there was a paper with Decairo and it was a negative outcome, and I think you're sharing literature on the contrary. So that would be it, to see how old that study is and where's the more current literature. I think that's where it's coming from. The pushback is there was a paper, so therefore, and maybe they haven't read the newest papers, and therefore they're saying just use myo.
I think maybe they're thinking about the fact that the history of the inositol sort of use in this setting dates back to about 1998. And it was actually first tested in Virginia, at Virginia Commonwealth University. They basically were using pure Decairo. And at very low doses, it was beneficial. And then when they pushed the dose higher, 1,200 milligrams a day, 2,400 milligrams a day, they got really bad results, really bad impact on ovarian function. So that was sort of the first, and actually they had formed a pharmaceutical company that they were going to try to get a FDA approval for Decairo as a prescription drug. And that high dose Decairo study that failed back in like 1999 or 2000 is really shut down the company. They abandoned the whole project. And for probably about 8 or 9 years after that, there was absolutely no work done anywhere in the world with inositols until the Europeans picked it up. And then, 5-6 years ago, Theralogix, we came out with this product, and we got a lot of blank stares from reproductive endocrinologists all over the country. And we used to call it NIH syndrome, not invented here. And so they were clueless that this stuff had been now studied in Europe and showing significant benefit. Now, finally, there are some pretty good, well-designed clinical trials that are getting underway. One at the University of Oklahoma, one at Penn State Hershey. Unfortunately, the pandemic has dramatically slowed enrollment, but both of those studies are underway.
Follow-up question or another question, again, those REIs. We have a lean PCOS patient who was told by the reproductive endocrinologist to continue using inositol because she doesn't display signs of excess androgens. The RE reasoned that the inositol would further diminish her already low testosterone. Is there any evidence that inositols will lower testosterone levels in patients who have a normal level? And I want to just kind of preface this that we've seen so much in acupuncture research and other studies and some other types of research that aren't even acupuncture with low-level laser therapy, that it's more of a regulating. So if this is normal and you're high, it will take high to normal. But if you're normal, acupuncture and some low-level laser therapy doesn't take normal, make you lower. So it's more of a regulator than a reducer. So I kind of wanted to preface that will inositol lower high testosterone, or will it take somebody who has normal low testosterone and make it even lower, is the question.
So there's never been a study that I'm aware of that shows that happens. And if you think about mechanistically what is going on in the ovary that makes the testosterone level go up, it is the excess insulin, okay, and it's the Decairo inositol levels in the ovary. Both of those two things together, the hyperinsulinemia and the Decairo, they both stimulate what's called the thecal cells, ovarian thecal cells, to produce testosterone. And so would supplementing a woman with myo-inositol who doesn't have excess testosterone production, would that suppress the normal amount of testosterone production that you want to see? Mechanistically, I couldn't see how that would happen. And again, it's never been shown, at least not that I'm aware of, in any study.
And so this makes me think of another question that came in, but I'm going to bring it forward now. With men, there is more research showing that men have PCOS-like metabolic disorders. And you have a background in andrology. And so for men that are overweight, but say have low testosterone levels, what have you guys used your product, and would your product be something that could be used in men that are overweight with insulin resistance or with diabetes, but again, tying it into, they actually have low testosterone, so they don't want it to be any lower? So
there are a couple of studies that have now been published using inositols in patients with type 2 diabetes. The other sort of the most classic example of insulin resistance. And I can tell you just anecdotally, I know of several reproductive endocrinologists here in the States who, men who had put themselves on Obesitol because their HbA1cs were kind of getting up into the worrisome range. And they wanted to try and basically improve their insulin sensitivity. And it's worked for those guys that have tried it. But would it have any impact on testosterone production? No, I can't see how it would. Again, the impact on testosterone production in women is because of its impact on the ovary. So I don't see how it would have any effect on men and their testosterone production.
Great. How do you take this product then? Is it between meals, with meals, 30 minutes before, after?
Yeah,
how do you take it?
It's twice a day dosing. And I think most of our customers, I think just basically, it's a powder. So it's the powder comes either in packets. We sell it in two different ways, packets or in a canister. Either way, the packets are each 2 grams. The canister comes with a scoop, which measures out 2 grams. And essentially, you just mix 2 grams with 8 ounces of water twice a day. So you could do that with breakfast and dinner. It's odorless, it's tasteless. It's got maybe a slight sweetness to it when you mix it with water, but it's generally very well tolerated. And so twice a day.
Okay. There were some questions that I think you answered yes to, but I'm going to just ask you to confirm. Can it be used for general weight loss? Can it be used for people that have diabetes?
Let me put it this way. I don't want to make that recommendation because that's not something sort of that's appropriate for me to say. I can tell you that there are studies showing benefit in type 2 diabetes, certainly not type 1 diabetes, where the problem is not insulin resistance, but just basically not enough insulin being produced by the pancreas. But and there's a pretty robust community on the internet that is using inositols for weight loss. So
okay.
Beyond that, that's as much as I probably should say.
Yeah, well, and again, because you shared the anecdotal of some of the male REs putting themselves on this for weight loss, so that's why I thought it would be that idea. Okay. Is it a sugar alcohol? They wanted to know because what about somebody that's diagnosed with SIBO? Would this aggravate it?
Honestly, I don't know.
Okay.
It's not I put it this way, it's not a huge amount of, the small intestinal bacterial overgrowth thing. There's, I think anecdotally, it's been shown that, certain lactose can stimulate bacterial growth in these individuals. It's not a huge amount of caloric intake in terms of, 4 grams a day. It's like, what is that, about 30 calories of carbohydrate. So I don't know. I really don't know the answer to that. But again, theoretically, you wouldn't expect it.
And one of your slides talked about there's thin PCOS. I think it was like 30 to 40%, and there's the overweight PCOS. Are there studies showing that my inositol or the Obesitol, the Myo plus Decairo, is beneficial in thin women that may not be exhibiting any insulin resistant issues?
Well, I think it depends on the endpoint that you're looking at. And also, I mean, there's still tremendous controversy over how one explains the sort of heterogeneity of the PCOS population. How you can have some women who have really bad insulin resistance and have PCOS, and then other women who have the diagnosis of PCOS, but they don't have insulin resistance. So what's the pathophysiology there? So, these things are still kind of being argued about. And so lean PCOS, it's funny, we were approached about 4 years ago by Baylor University in Texas. One of their REIs was very interested in lean PCOS, and he wanted to do a study looking at the metabolomics of lean PCOS using either placebo or Ovasitol. And so we supplied him with both the placebo powder and the Ovasitol. And After 2 years, I think he wanted to have 20 women enrolled in the study. After 2 years, I think he had 4. It's just very difficult to make the diagnosis of lean PCOS because people just are still scratching their heads as to where do these women fit in. So it's a little bit confusing. I don't think we know the answers.
And this question came in before you actually talked about it on your slide. So I think it was answered in your talk, but let's just say it one more time. If patients are already on metformin, is it safe to take the Myo plus Decairo concurrently, and is it beneficial?
Yes, it's safe. And there was actually just a study published literally a month or 2 ago showing that the combination appears to be better than either one alone. And again, I don't remember the exact endpoints that they were using in that study. But we know it's safe. You're not going to get hypoglycemic. But I mean, there's enough data to basically say it's as good as metformin alone without all the GI side effects. I mean, the biggest issue with metformin is that about 20% of patients just don't tolerate it because of all the GI upset it causes. Now, don't get me wrong, metformin is a really great drug, but it's been around for 50 years and it's now being investigated as a longevity drug. There's some really fascinating data about the potential benefit of metformin in older adults. I think the name of the study is TAME, Targeting Aging with Metformin, that they're doing right now in older folks, not people in their 30s and 40s though.
Let's see, we're getting close to wrap up time. What about patients that are anovulatory? They don't have PCOS. Could inositols be helpful for them in regulating their cycles? Because of the mechanism, I think you mentioned about the inositols helping with the FSH.
Yeah, I have to tell you, I don't know. I did not treat, in my practice, I was treating the male half of fertility couples. So I don't have any direct experience treating women who are anovulatory. There are other causes of anovulation. PCOS is without a doubt the most common, but there are others that are, clearly related to hormonal, issues, sometimes central, lack of gonadotropin releasing hormone, those types of issues.
Great.
So
I want to thank again Dr. Mark Ratner for this lecture and the Q&A, and I want to thank the gang at Theralogix for sponsoring this lecture. A couple of things I want to remind you guys, the listeners here, is contact Theralogix, that's IX, directly. They have many papers and research on all their products because everything that they create and sell, they have evidence-based behind it. So if you're looking for more and more literature and some of the stuff that was discussed here, contact Theralogix directly. They've extended their special discount for IFS folks until August 31st, 2021. So check that out as well. Ask them about that. And then the handouts from this lecture and the CoQ10 lecture, you can get that from Theralogix as well. And you can check out the Healthy Seminars Facebook page to see the videos as well if you can't find it on the IFS website, or Theralogix has copies of that as well. So I just want to let you know many ways for you to continue your continued education, your learning, your confidence. And Theralogix is an excellent resource. And then again, they've had some products that they have some research behind. And as Mark shared in his talks, often their products are being used in studies. So that's always great to know as well. So do contact Theralogix directly if you want the handouts, if you want information on samples, if you want information on the research they've been doing, and any specials that they're offering. Dr. Mark Ratner, thank you once again for this informative lecture. Much appreciated. Thank you guys for your questions. Really good questions today. And Ian over there at Theralogix, thanks for sponsoring the IFS again and putting together the two lectures, one on CoQ10 and fertility and this one on inositols and PCOS. Much appreciated.